It is not uncommon to have intraoperative floppy iris syndrome, and here we will see this one extreme case of such a situation. This is the gentleman who was planned for cataract surgery, and as we can see, the pre-op dilatation is not very good, and the iris also looks little disturbed. This is the fundus photograph, which shows a dense cataract and a poor view of fundus, and this is the surgery, the point where we are starting the surgery. A clear corneal incision has been made, and as we can observe, the pupil is not very well dilated, and these kind of iris, they don't respond to mydriatics. And more so, the muscle and the iris structure is such that it flutters during the surgery, and this mechanical disturbance contributes the progressive meiosis and inability to maintain a dilated pupil during the surgery. And this will complicate the situation because all form of extracapsular cataract surgery require that the pupil should be very well dilated. Now, as you can see, that once the anterior chamber is inflated using viscoelastic gel, the pupil dilates a little bit, but it doesn't help much. At this moment, the patient's head is being adjusted so that the fluid would drain automatically towards the temporal side, and this helps in these situations because accumulation of fluid will definitely cause further issues in visualizing. And here the capsulorhexis is being started, and the first problem in these situations is that the pupil is not very well dilated, so the capsulorhexis has to be done on a basis of intuition. Another option which I should mention here is that using pupillary expansion devices, which includes hooks and various kinds of rings, and one can also resort to mechanical sphincterotomy using a scissor. But all these methods, the alternative is that you can perform this surgery without aid of such tools, and this will not cause trauma to iris in a way the sphincterotomies can cause. And this can be considered as a proof of concept that this is possible, that one can do phacoemulsification in IFIS, that is intraoperative floppy iris syndrome, and that too with such a small pupil without causing any accident. So with time I have evolved that it is possible for me to take up these cases on elective basis and still be confident. It is only that I take few precautions which I will mention as we will go along. We can see the iris flutters along with every movement of the fluid inside the eye, and this can be recognized early, and one should be very observant about these things, because once you can identify, then it is a possibility or a chance that you can modify the surgery so that the iris and the pupil may not cause complication during the surgery. However, we will do the phacoemulsification. One option is that one can switch to manual small incision cataract surgery, and the key factor in making incision is that the incision should be pretty long. So here I have made a tunnel which is long enough, and this will seal better and also end more centrally so that the iris root doesn't come into the flow and is prolapsed out. Once you have done the initial removal of the superficial cortex, we can bury the tip and also proceed for direct horizontal chop technique. And I have also seen that some amount of iris fluttering or distortion of the iris actually helps in visualizing those portions where the iris is prolapsing out or is engaged within the tool. And this is akin to using an iris hook, which also causes a mechanical pull on the iris tissue so that the iris is bunched up towards the periphery, clearing the central area. Here the horizontal chop is nearly being done blindly, but with intuition and with experience one can safely chop the nucleus in spite of poor mydriasis. The key factor is patience and very careful movements. Now one more problem is that once you start emulsifying the creases, the iris, which is very fluttery and have no tone, will also come into your aspiration port, and if phaco power is applied, it will get damaged. So one has to be very careful and have good foot control over the fluidics so that the iris tissue is not aspirated and damaged. There are some bubbles in the anterior chamber sticking to the corneal endothelium. They can be aspirated so that the view is clear. Once we have removed 1/4, we can proceed to remove rest of it, and the key is that once we have started emulsification process, the phaco tip has to remain in the center and rest of the work has to be done with the side port instrument. Rotating the half nucleus, and you will notice that I have rotated in such a way that once I chop the piece, it remains engaged to the phaco tip and it can be emulsified rather than repositioning the phaco tip or the piece. One more problem is there that once the piece is consumed, there is some amount of surge and you can have the iris tissue just in front of the phaco tip. Once the consumption of the phaco piece is done, nucleus piece is done, one can aspirate the iris. So working in such a close and a very constricted space requires good amount of control and acute observation so that nothing unwanted is aspirated into the phaco tip. Working in the central area where you can safely emulsify the nucleus at the pupillary plane without engaging the iris is the key. One has to keep map of the amount of nucleus removed so that there is no hidden piece remaining behind, and one has to keep on having a map that how much nucleus one has removed and how much there is remaining. Once you are sure that all the pieces have been removed, then only one should resort to removing the epinucleus and the cortex. This is one trick there when you can use the chopper to pull up the iris tissue away from the area and expose the underlying cortex. Here we are trying to remove the epinucleus, and I had once aspirated this iris tissue, although the phaco power was not turned on. So as you can see, the iris is still intact and has not got any damage. Once the epinuclear plate is left behind, it is safer to use irrigation aspiration cannula and always replenish your anterior chamber with viscoelastic, and remember not to inject viscoelastic behind the iris. It will cause immediate iris prolapse. Using irrigation aspiration cannula and a T-shaped dialer which will be used to retract the iris tissue so as to visualize the cortex underlying the iris. One can start from aspirating those portions of the cortex which are visible in the central area, and if it pulls up a larger chunk, one should continue. And we can just look at those pieces of cortex which are lurking behind the iris, and once there is no ability to hold them or no approach to those visible chunks of iris, then one can resort to elevating and pulling the iris to the periphery so that the underlying cortex can be exposed. So same trick is being used here. However, the posterior plate is sometimes tricky, and one has to remove or pull the iris away so that one can expose the cortex fiber and engage it. Foot switch control along with good coordination between the two hands is essential to perform this type of surgery. Now there is a flat plate lying on the posterior capsule which will require some amount of manipulation or engaging one end of this so that this plate can be lifted up. It is a job which requires a lot of patience, and once you have clear area, you can stop your aspiration and go underneath this and then engage this plate of epinucleus. The aim is to deform this plate so that it can be pulled up into the pupillary plane and can be aspirated. Carefully removing the T-shaped dialer, it is shaped in such a manner that it may get engaged, and here I am showing that how to entangle it by some force and by some maneuvering. The pupil is not round, and that is because a portion of the iris has got some damage because of repeated aspiration, and another portion towards the side port is damaged because of repeated prolapse. However, the cataract has been removed, and as you can see, the glow is uniform and good. Proceeding on to implanting the intraocular lens. This is a hydrophobic monofocal intraocular lens with negative asphericity, imparting some amount of extended depth of focus, and this is from Oro Lab. It comes in a preloaded injector system, which is very convenient to use. Engaging the optic haptic junction and dialing the IOL into the bag. Dialing requires not only a tangential force but also some amount of pushing force towards the floor so that the IOL goes into the bag. Now at this moment we can see and appreciate that the pupil is something like 2.5 to 3 millimeters in size, which is extremely small. However, surgery has been completed, and the post-op results on the day 1 will show us how much cornea has been disturbed. One can have a situation where, because this phacoemulsification is performed in the pupillary plane, one can have pieces of nucleus touching over the endothelium, which may cause later on some decompensation, which will be evident as corneal haze and edema on the day 1. However, we will see what happens in this case. I have been very careful to divide the pieces into smaller chunks so that the possibility of chunks or nuclear pieces to touch the endothelium is least. Once all the viscoelastic gel has been removed, one can inflate the chamber and has to take care that you have to reposit the iris first, and then only one should inflate, otherwise it will simply cause more prolapse. Any prolapsing fiber or fibril of the iris should be reposited back nicely, otherwise it will keep the wound open, allow the leakage, and also the remaining iris is going to follow up. So as we can see, some fibers of the iris tissue were engaged in that wound, which have been relieved. This iris is absolutely atonic and will flow out with the flow at any moment whenever it is possible for it to come out. Sealing the anterior chamber with adequate pressure is important, otherwise the self-sealing incision is not so functional. There is a small fiber which I suspect is from the syringe or plastic fiber, which the source is not known, but we must have always observed there are a few fibers at times which are seen during cataract surgery. The anterior chamber is hydrated and intraocular pressure is elevated to create a seal. This is the day 1 post-op picture, and we can appreciate that the cornea has not been damaged and it looks healthy. However, a portion of the iris in the superior nasal quadrant is slightly shaved, which should not bother the visual outcome, and this patient had good visual acuity with no complaints. Thank you.